Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hello, this is Lily Shockney. I am pleased to introduce the third of 6 audio presentations where Johns Hopkins Medicine experts talk about COVID-19. Epidemiologist and internist Dr. Lisa Maragakis offers updates on COVID-19, what we have learned from this virus, how it invades the patient's lungs, short and long-term impact on other organs, the potential of new treatments and a vaccine, and the threat of its return. Keep up to date with the latest women's health information by visiting A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey, or by following A Woman's Journey on Facebook and Twitter.
Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining this evening's webcast, COVID-19 and Update. A Women's Journey strives to improve your well-being through health education, and we encourage you to visit hopkinsmedicine.org for updated information about COVID-19 from Johns Hopkins infectious disease specialists and other experts. You can also visit A Women's Journey to learn about its timely podcast, videos, and educational programs. Tonight's speaker is infectious disease and epidemiologist Lisa Maragakis. She will provide the most recent information about COVID-19, status of the development of antibody testing, and research for a vaccine. Following her remarks, Dr. Maragakis will respond to many of your questions. Please use the Q&A icon found on the bottom of your screen to ask a question. Tonight's webcast will conclude at 8 p.m. Tomorrow you will receive an email asking you to complete a 5-question survey about this webcast and offer suggestions of additional webcasts that you would find informative. You also will find a video of tonight's and all webcasts on A Women's Journey website, hopkinsmedicine.org/A Women's Journey. And now I'm pleased to welcome Dr. Maragakis.
Thank you very much, Kelly, and to everyone at A Woman's Journey for the kind invitation for me to join you tonight and talk about this important topic in these extraordinary times. I'll begin by making a few remarks about the novel coronavirus, or SARS-CoV-2, as the virus is known, and the disease that it causes, or COVID-19. And tell you some of the latest things that we are seeing at Johns Hopkins Medicine as we care for these patients, and also start and participate and lead research studies looking for effective therapies, looking for ways to prevent the disease through vaccine development, and developing diagnostic tests to help chart our way back from this midst of the pandemic in which we find ourselves. So I'll start by saying a few words about coronaviruses in general. They have been with us as human pathogens for a very long time and are actually responsible as a family of viruses for at least 10, if not up to 30% of all upper respiratory infections, including what we generally term the common cold. So these are well-known human pathogens and generally considered to be inconsequential. However, as we know, this particular version of a coronavirus is not at all inconsequential, and it follows other family members, including SARS, or the sudden acute respiratory syndrome, and MERS, as coronaviruses that cause extremely severe respiratory illness and death in many people. So SARS emerged in 2002, 2003, again, is from this same family, and had a mortality rate that was around 30%. MERS emerged much later in the Middle Eastern area of the world and had a mortality rate around 10%. Both of these viruses have something in common with the current SARS-CoV-2, or the virus that is now circulating, in that the receptor that they use to really bind in humans and cause disease is located in our lungs. And that's why with these three coronaviruses, we see pneumonia and severe pulmonary disease as opposed to an upper respiratory infection. And the protein to which both SARS and this SARS-CoV-2 bind is an angiotensin converting enzyme, or ACE2 protein, that is found in our lungs. All of these apparently are zoonotic infections that have come from animal sources and have found a way through mutation, which is very common in RNA viruses, to jump from one species to another, sometimes through intermediary animals, and then to make their way into humans. When SARS-CoV-2 first appeared on the scene in China in late December, mid to late December, data started emerging, and I think initially there was a lot of confusion around the mortality rate of this new virus, and it was notable that the mortality rate was dramatically lower than SARS and MERS had been. And so I think that fact alone led to some discounting of the potential impact that we now know has come from this virus. Interestingly, when you look at a pathogen from the pathogen standpoint, success is sometimes driven by having a lower mortality rate and being more efficient transmission person to person, but not killing their host. And that's what we've seen with this virus. We are now in the midst of transmission widespread in all states in the United States and really around the world. And we all know, I'm sure, the significant challenges that we are facing. Most recent data show that we have counted at least 2.5 million cases worldwide, with over 175,000 deaths. And even this may be an underestimation. Clinically, the incubation period of the infection can be anywhere from 2 to 14 days, but is often in the middle, around 5 to 7 days. And what we know is that the disease presents as a flu-like illness, often with fever, shortness of breath, cough. Sometimes patients have very mild or no symptoms at all, or may present with a sore throat and a headache, or body aches, myalgias, and just generally feeling unwell. There are some unique features, I think, that have emerged, and in particular, I would point to the fact that severe disease can present quite late with this viral infection. So typically when we think about respiratory viral infections around day 10 to 12, you would expect to be feeling much better. And with this virus, one thing that we've noticed is some patients actually worsen in that time frame around day 9 to 11, even sometimes after initially improving and then suffering what looks like a relapse. We're not sure exactly why this happens. In some cases, it may be due to the fact that the degree of hypoxia or low oxygen absorption because of the pulmonary infection has led the person to finally tire out, and other organs become involved in the infection and cause the worsening clinical picture. Sometimes this is known to be myocarditis, or an infection of the heart muscle, or multi-organ failure in the setting of the low oxygen levels. So it's something to watch for, certainly vigilance, even for those who are recovering at home or who have been admitted to the hospital and then been discharged. We have to remain vigilant that even after they seem to have recovered, that they may have that clinical worsening. A few other things I wanted to mention about what we've learned recently in the United States. We have seen a much younger population of patients admitted to the hospital and even requiring intensive care interventions, and sometimes unfortunately dying from the infection. Initially, reports really centered around older individuals and those with a lot of comorbidities, underlying heart disease, pulmonary disease, diabetes. And now really we see a much wider, in the United States, age distribution, really from the majority of patients from ages 30 to 60. Although we do, of course, still see more severe consequences and a higher mortality rate at the extreme of age. The other thing that is notable, I think, is diabetes, and in particular obesity, as a risk factor for severe disease. And this has certainly been noticed in Johns Hopkins Medicine amongst the patients who have required admission, and particularly those who have required mechanical ventilation, that obesity seems to be a significant risk factor for severe consequences of the disease. Our pulmonary critical care colleagues have certainly noted a lot of unique features, although the pneumonia does cause very low, very, very low oxygen saturation levels. Thankfully, the lungs are not stiff and are actually quite readily ventilated using a mechanical ventilator. And so that is a blessing, that it is dissimilar from other infections that sometimes cause very stiff lungs that are hard to ventilate, and that's not the case for these patients. One unique feature is that almost all of the patients require proning, which is to turn the patients onto their stomach, and this helps the lower parts of the lung and the back part of the lung inflate better and oxygenate the blood in a better way. It's a very labor-intensive process for the teams that are caring for these patients to flip them. And you can imagine, especially if they're on a ventilator and they have a endotracheal tube and IVs and other devices, it takes quite a few people to turn the patients back and forth. And so our teams have become quite good at doing this, and we actually have specialty teams called proning teams that are helping our frontline providers with this task and making sure that it can be done safely and efficiently for our patients. I want to say how very proud I am of all the healthcare workers that are doing this work on the front lines. They are working tirelessly every day and learning a lot and improving their care and really coming together as a team. We have employees that have redeployed from their usual units and their usual jobs and gone back to be trained in additional skills to make sure that they can provide the very best care to the patients and the timely expert assistance to their colleagues, so that the whole teams can come together and make sure everything is done optimally for these patients to help them with their recovery and their survival. And although we have seen a number of deaths and the mortality rate does seem to be somewhere in the range of, I would say, 0.7 to 1.5%, which is still quite significant and approximately 10 times higher than what we see with seasonal influenza. We are definitely focused on the success stories and celebrating every patient who is extubated, who is taken off the ventilator, and of course the many discharges and success stories. So trying to focus on the positive as we confront the terrible reality of this disease. It has really required Johns Hopkins Medicine and hospitals across the United States and the world to redesign healthcare delivery from really the outpatient setting and inpatient setting alike. In order to deal with the incredible surge of patients who are requiring care, sometimes all at once, we have worked with ambulatory colleagues to set up call centers so that patients who have questions, the worried well or the mildly ill, can get the information that they need to keep themselves and their families safe. And also to recover at home and get the testing that they need if they do have symptoms, but all the while staying out of the emergency department so that they can stay safe, and also we can unburden the acute care setting while caring for patients remotely by telemedicine and home care and other strategies. And then within the healthcare system, it has been an incredible transformation of reallocating our intensive care and acute care services unit by unit from non-COVID care to the care of patients with COVID-19. And as I mentioned, redeploying staff, retraining some staff for the skills required to care for these patients, and all the while making dramatic changes to our healthcare delivery to free up the capacity, strategies like postponing elective surgical procedures so that we have the bed capacity to allocate to the care of patients suffering from this disease. And then, of course, maintaining essential services for non-COVID related illnesses that are urgent or emergent. And that care is ongoing as well. So it's been an enormous challenge, but again, I'm very proud of our teams at Johns Hopkins Medicine, and I know across the nation and across the world that our healthcare colleagues are facing similar challenges and meeting them bravely and quite well. I did want to say a few things about the clinical care and the treatment. Unfortunately, we do not at this time have effective, proven therapies, antiviral therapies, or medications that can be given for the illness, but that does not stop us from providing the very best supportive care through pulmonary critical care, supportive mechanical ventilation, as I've mentioned, and treatment of multi-organ dysfunction, sometimes clotting disorders that can arise with the onset of the illness, and in some cases, what we call cytokine storm, which is a very exuberant inflammatory response that can happen in response to the viral infection, and really trigger low blood pressure, a sepsis-like picture, and multi-organ failure that requires critical care services. I don't want to leave you with the impression that all of the patients are like this. However, we have many patients who are on our acute care services, meaning that they needed admission to the hospital but did not require mechanical ventilation, and they are receiving oxygen therapy and IV fluids and support for their illness until they can return to their homes. City and states and public-private partnerships have come together to put together plans and healthcare delivery for patients after discharge. And we are still working through a lot of those issues to understand exactly how much capacity is going to be required for rehabilitation services, for patients who may have a prolonged time on mechanical ventilation and need to go to a place where they can continue to receive care and come off of the ventilator, and also opening alternate care sites such as in convention centers or other large buildings, so that we have a way to decompress the hospital and admit new patients on an ongoing basis. And in Johns Hopkins Medicine, and I imagine in other health systems as well, we have pooled our resources and really come together to work as one organization and standardize our approach and share our resources and transfer our patients amongst our various facilities to optimize our whole health system's response to this crisis. And of course, we see different challenges in different geographic areas, and the virus hits at different times. And so we have been able to successfully use that strategy as well to make sure that no one hospital is overrun at a given time. I'm sure everyone knows that nursing home patients, nursing home residents are at particular risk for a variety of reasons, including their age, sometimes comorbid illnesses, and also, being in an institutional setting in close proximity to staff and other residents. And so this is an important part of a community addressing the pandemic, making sure that we have systems in place to partner with local long-term care facilities and ensure that they have what they need so that those patients don't become ill and need to come all at once to a hospital, which could cause a lot of adverse events for those residents, and also a surge that could overwhelm the hospital and healthcare system. Similarly, we're working closely with our communities and political leaders to ensure that other high-risk, vulnerable populations are receiving the services that they need and have alternate care sites so that they can be quarantined if need be, such as citizens who are experiencing homelessness and individuals who are in group homes. And we're also keeping an eye on correctional facilities, which are at risk for outbreaks, and plans are in place to deal with that as well. There are a number of agents that are under investigation. We have clinical trials ongoing at Johns Hopkins Medicine and at other centers throughout the nation and around the world, looking for antiviral agents that may be effective against this virus. One of those is remdesivir, and it has shown some promise in at least case series that have been reported in the medical literature. And at Johns Hopkins Medicine, we are participating in that clinical trial and are anxiously awaiting results to see if it will be effective. There is a suggestion from in vitro data that this antiviral is effective, at least in the lab, and hopefully will be helpful to patients as well. It is an IV medication. I'm sure everyone has heard of the oral medication hydroxychloroquine, which is an anti-malarial agent and also used for a variety of rheumatological conditions. And it is also in clinical trials. No data are available yet to suggest that it is effective, but it is being studied in an ongoing way. Another notable agent to mention is DAS181, which interferes with the viral particle's ability to bind to the receptor. And so trials are ongoing for that nebulized medication, which is an inhaled nebulizer medication. I can speak briefly also about vaccine development and just say, unfortunately, although we had some candidate vaccines for SARS that are a platform for developing a vaccine for this current SARS-CoV-2, we are still many months away from having an effective vaccine. There are candidates and ongoing work is being done, but we must proceed cautiously because there are some pitfalls that could actually lead to worsening of disease or ramping up of the immune response that could be harmful. And so we must proceed with caution, but cautiously optimistic that eventually we may have a vaccine against this disease. But right now, the most important thing I think that we have seen work around the world is the strategy of infection prevention and hand hygiene, and specifically social or physical distancing. So really just not letting the virus be transmitted from person to person, and by keeping more distance between ourselves, and in many cases by using a universal masking approach to prevent respiratory droplets from being transmitted from person to person. So these are the very basics of infection prevention, particularly for respiratory viral transmission. And that, along with the kind of emergency response and preparedness and healthcare that I've described to you this evening, are really our cornerstones of our response to save lives and get through this pandemic. We are beginning, along with many others, to chart a course for how we get back from here to more of a normal situation. And I'm sure we'll talk more about that during the questions and answer. So I think with that, I will pause and see if we want to start maybe handling some questions and having a conversation so we can see what's on everyone's mind.
Thank you very much. Very informative. And yes, we do have lots of questions this evening. So why don't we start with, this is sort of a broad general one, but what's coming in, a lot of people are concerned, could the virus mutate into a more deadly strain?
Sure. So SARS-CoV-2 is a RNA. It's a large enveloped RNA virus. And what we know about RNA viruses is that they do have a lot of mistakes, for lack of a better word, in their replication process, and that leads to mutations. So the mutation rate in an RNA virus is quite high. So we would anticipate mutations will occur. Whether that leads to a more lethal form or a less lethal form, is difficult to say. And as I mentioned earlier, unfortunately, this version of the virus kind of has found a perfect storm of characteristics in which it is able to be efficiently transmitted into human, also apparently transmitted from people who don't even know that they have the disease, which is a particularly insidious characteristic for any pathogen to have, that it can get from one person to another without the first person even really knowing that they're ill. And then having a relatively low, I don't want to say low, I shouldn't say low, but a mortality rate that is not in the 10 to 30% range, like I mentioned for SARS and MERS. As we know, SARS in 2002 and 2003 actually disappeared. And part of the reason that it disappeared is that it had such a high rate of critical illness amongst the people who caught it that they all almost ended up in the intensive care unit, and many of them died. And that was a tragic, frightening experience, but it also allowed public health officials and healthcare personnel to isolate the virus and do contact tracing and really track down everyone that was exposed and contain the transmission. And it was not as easily transmitted from person to person. And so that allowed us to be successful in stamping it out, but not so with this one.
Right. So does that mean that you expect perhaps a second phase of this virus into the winter?
So unfortunately, we just don't know. There's a lot that we have to learn about this virus, and no one has a crystal ball. However, I do believe that the characteristics of the virus mean that we are likely to see this come back, stay with us, and or come back in the fall. I would be surprised if it goes away entirely, just based upon how far and wide it has spread and the characteristics of the virus itself.
So on that note then, when we're talking about masking, and we've heard a lot about that, of course, in the news, and a couple questions here about masking that people have sent in. Really, basically, what really works is the bottom line. For example, if you're wearing a mask and you pass a runner or you're in a grocery store, does this really prevent you from getting the virus? Or is it really just for comfort? Because the healthcare providers need to wear the PPEs to protect their entire face and body. But how is that different, from our exposure than from the healthcare workers?
Right. So unfortunately, this is also a question that we are still searching for the answer about the mode of transmission. And there may continue to be some ambiguity about it. And that is really whether it is spread by the droplet route, like most respiratory viruses are spread by large droplets when someone coughs or sneezes, and those relatively large respiratory droplets fall to the surface, to the floor or surfaces after no more than about 6, maybe 8 or 10 feet in front of the person who coughed or sneezed. And in contrast, airborne particles or airborne transmission, such as we see with varicella, the virus that causes chickenpox, or tuberculosis, these are little tiny droplet nuclei that can remain aloft for a long period of time and circulate on air currents, and those can be inhaled and cause disease. And so there's still a question about this virus, but the current recommendations are to use a respirator as if it is transmitted by the airborne route. And so in the healthcare settings, if personal protective equipment is available to allow us to do so, we wear N95 respirators, which are very tight-fitting mask-like respirators that don't allow any air to go around the device, but all of the air is entrained through the filtered mask-like respirator. There's other kinds of respirators that we wear, including the hoods that you see in some of the pictures in the news media that are really HEPA filtered air that's entrained and then blown down in that hood over the healthcare worker's face. And there's other kinds of half face respirators that are worn as well. In contrast, the masks that we wear in public, the cloth masks or sometimes medical masks, but they're just like rectangles, and you know that some of the air that you're breathing in is going around that mask. The primary purpose for that is to control your own secretions and protect others around you. And so they're really two different reasons for wearing masks. And so I think the main takeaway is that if you're going to the grocery store and you put on a mask because you have been told to, or because you feel better when you're wearing it, just know that you still need to keep physical distance from other people and wash your hands and be very cautious of being around anyone who seems to be ill, because that mask itself is not protecting you. It's controlling your own coughs and sneezes to protect everybody else around you.
Thank you. Another question, what long-term effects do you think COVID will have on patients who have recovered from the disease, like lung, kidney, cardiac, brain, or any systemic issues? Because as we've heard, some of the symptoms possibly are like loss of smell and taste, and will you regain them back or not?
Mm-hmm. I hate to keep saying I don't know or we don't know yet, but I think that these are more questions that remain to be seen. But we are learning some things. And so, as I mentioned earlier, we know that in addition to the lung, that the virus actually does cause infiltration and disease in the gastrointestinal tract. It can affect the heart and the kidney, among others. I don't think we know as much about the neurologic effects of the virus itself, but of course, when we think about long-term sequelae of an infection, it could be from effects of the virus and the infection itself acting upon those organs because of infiltration and inflammation. Or it could also be because of the critical illness that it causes. And so what we do know is that patients can have extremely low blood oxygen levels, for instance, and become critically ill. And that process alone can have an effect on neurologic function and the other organs. So I think we don't yet know the long-term sequelae of recovering from this viral infection, but I think we are seeing the wide range of effects that we often see with critical illness and with pneumonia that requires mechanical ventilation. With regards to the loss of taste and smell, I think that many people, and I would keep in mind that the majority of people who get this infection are mildly ill and not in the hospital. And many of those are the ones that have lost their smell or taste, sometimes as the only symptom. And it does seem to come back. So that's the good news.
It is good news. So how about the accuracy of test? Is there a high percentage of false positives, would you say, or how do you feel about that?
Mm-hmm. So testing has been a very difficult topic, at least in the United States, because we have been so challenged with testing reagents and just having access to even the swabs and the testing materials to test a large number of people. And that's for a variety of reasons. The sensitivity and specificity of the test varies depending on which testing platform is used. Most of the tests are reverse transcriptase PCR tests. I don't know of any of them that have false positive problems unless there's a problem in the process and contamination of the samples. But in general, we have seen some very likely false negatives in patients for whom the clinical picture really strongly suggests that they have COVID-19, and yet the test, for whatever reason, is negative. And we have seen some of these patients later test positive after they get a bronchoscopy and a lavage of the lower airways that reveals the virus. So no test is perfect, but actually most of the versions I think have performed very well. It's been more an issue of having sufficient reagents and swabs to do the testing.
Thank you. Does the antibody test confer immunity to the person and an inability to pass COVID along to others?
So this is a burning question, which we are working to answer. And in fact, we're launching a study at Johns Hopkins Medicine really as we speak to try to answer this question. Again, testing is key here, and having access to serology tests to know who has antibodies, both IgG, IgM, maybe IgA, or a total antibody test, in order to know that there's evidence of a prior infection, and you can see evidence of an immune response. What we don't know yet is whether that antibody confers immunity so that that person will not catch the virus again. But we're going to do a study, and many others are also asking this similar question in research studies.
So would you say then that tests are successful in detecting antibodies? And if so, do we know how long antibodies are protective?
So the test can detect the antibodies. And again, there's different kinds of tests and different platforms. So one size doesn't fit all, and we have to be careful and evaluate each platform to see its sensitivity and specificity. So it's always important to have good communication with the immunology lab about the specific test characteristics before relying on the answer. But there are definitely tests that have been developed that are performing quite well. But as yet, we don't know the answer really to the immunity question, and then how long such immunity might last.
Thank you. A lot of people have been asking about the theory of the weather. Does the weather have any effect, whether you're in warm weather or cold weather? Does that have any effect on the virus?
So most respiratory viruses occur in colder, drier weather, and we see patterns of influenza and respiratory syncytial virus and other viruses typically in the winter months in all parts of the world. However, typically when a new virus comes along and no one has immunity because it is a new virus, like the one with which we're dealing now, the weather has less of an effect, apparently. And we've seen this before with influenza strains that have come suddenly in the summer months unexpectedly. So I think that's what we're seeing now. If I had to guess, I think this virus is likely to remain with us, and I would predict that it might then have seasonality in the future where it might co-circulate with other respiratory viruses, but we just don't know yet.
Thank you. So what do you see moving forward, if it's possible, to when people are starting to think about or when we're allowed to start going back to work or kids going back to school? What are your thoughts about that in reference to the COVID virus?
So this is the difficult question of really charting a course from where we are to where we would like to be, which, back to normal. And that is a very difficult question, especially when we still see evidence of transmission, person-to-person transmission, and we know that we have vulnerable citizens who are at risk for severe consequences of the disease. So, I guess my thought would be that we're really going to have to focus on the basics of infection prevention and the strategies that have been successful so far, like social and physical distancing. Obviously, we would like to have a vaccine and we would like to have antivirals, and those would be critical markers that would allow us to more rapidly resume normal activities. But in the meantime, I think many of us are thinking about a staged approach of really following the science, following the data, and ensuring that the number of cases in any given geographical area have at least plateaued, if not started to decrease, before we cautiously start to take steps to resume some of our normal activities. And then incorporating all of these infection prevention strategies into our daily lives. I suspect that some of this will happen because of our own heightened awareness now after going through this, and our concern for our own health and those in our families and our communities who are perhaps more vulnerable to the severe consequences. So I think going to the grocery store right now, which we all have to eat, so we have gone to the grocery store, and it's been amazing to see how many changes have been made in typical grocery stores across the nation, and I suspect the world, to adjust the way that we stand in line, and how crowded the store is allowed to get, and how vigilant and diligent the staff are about disinfecting environmental surfaces and maintaining physical distance. So those kinds of strategies, I think, are the ones that we will need to continue to use as we open up.
Thank you. Can transmission actually come from the soles of shoes?
So the United States Centers for Disease Control and Prevention recently did release a statement and some data about the soles of the shoes. And so I think technically the answer is yes. The floor and the bottoms of your shoes are notoriously known to be contaminated with a wide variety of things. However, as an infection prevention person, I don't spend too much time thinking about the risk of the floor or the bottoms of the shoes, just because pathogens really tend to stay where they are on environmental surfaces. And so if you use common sense approaches to not interacting with the bottoms of your shoes and the floor, with your hands and other objects, that can be a really good way to protect yourself. And one bright spot is that this virus is not difficult to kill with typical disinfectants. So, diligence in cleaning surfaces with our normal disinfectant is sufficient.
Thank you. What do we know about development of immunity after having the disease? Do we know anything about that?
So we don't, unfortunately. The antibody studies we discussed earlier are going to help us understand more about the antibody response to the natural viral infection. But we don't yet know if that confers immunity. We have seen, as I mentioned, what look like relapses, but I don't know that we have definite documentation of reinfection, of someone getting the infection twice. But that's certainly an active area of interest, and will be something that will be incorporated into the scientific studies of the serology testing. And we will look with great interest to see if anybody who develops antibodies does have a documented second episode of infection.
Thank you. Is there a benefit to antibodies from SARS?
That's a great question. I don't know the answer to that. So like a cross-reactivity, that if somebody who was previously infected with SARS were to be exposed to this virus, I don't know the answer. That's a good question. The two viruses, the original SARS and now this SARS-CoV-2, are highly related. So I suppose it's possible that there might be some degree of protection for the relatively few individuals who were infected and survived SARS.
Thank you. Why do you think children, for the most part, have been spared?
Oh, that is a great question. I don't know the answer. It's one of the really blessings, I think, that for which we are all grateful, that the children don't seem to be susceptible, or at least don't seem to get critically ill. as often with this infection, although there certainly have been cases and tragic cases of children dying of it. But I don't think we know the answer to that yet. It may be, due to something about their lung function. It could be expression of proteins, but I don't think we know the answer right now.
And what test is available at Hopkins, and how do you go about that?
So I actually have to give so much credit to our colleagues in our microbiology lab and pathology at Johns Hopkins Medicine. I can't say enough good things about them. And actually, this week or last week was National Laboratory Medicine Week. And so a really great time to celebrate all the wonderful work that they've done. At Johns Hopkins Medicine, our pathology colleagues developed an in-house test that is an RT-PCR, reverse transcriptase PCR test. And they developed it on their own and also filed what was described to me as a mountain of paperwork to get regulatory approval to perform the test. And we are so grateful to them for doing that. Of course, the CDC test was also made available early on, but was a very manual process and also had some issues with parts of it that did not work as anticipated. And so for quite some time and continuing to this time, our home in-house developed test was the backbone of our testing capability. In addition to that, our microbiology lab has brought in-house and validated 6 additional platforms, an incredible amount of work, and just a very resilient, I think, approach, because due to the shortages that I've mentioned several times tonight, we have been challenged in almost every way to have adequate reagents, adequate testing swabs, and each type of test has its own requirements for specific components of that test. And so that is why we have seven different kinds of tests in our institution right now. They all perform very well, and they're all essentially a similar technology using PCR, but just allows us some flexibility and resilience. If we run out of certain test kits, we can turn to another method.
Another question. If one household member becomes positive, should all household members remain quarantined?
So household contacts are at high risk when one individual is diagnosed with COVID-19. Then yes, I would say that everyone else in the household should consider that they have been had a significant exposure to the virus. What we advise in that scenario is that the individuals remain in quarantine and separate themselves as much as possible from the ill individual if they're still in the home. Trying to, if possible, use a different room, wearing masks if they need to be in a shared part of the home, and that kind of thing. And certainly being very vigilant among the other household members if any symptoms develop, and then getting tested.
Thank you. Do you recommend taking the annual flu vaccine in the fall?
Oh, yes, absolutely. So we actually at Johns Hopkins Medicine require it for all of our staff and employees. And that's really a patient safety initiative. It's good for the staff too, to protect them and their families, but also it prevents illness amongst our workforce that could be a threat to our patients were we to unknowingly be shedding influenza and transmit that to vulnerable patients who may be at risk for severe consequences of influenza. So yes, I mean, I think this current situation makes us realize how lucky we are to have a vaccine, however imperfect it might be. But we should definitely get the influenza vaccine. And this coming fall, it'll be especially important if we are faced with having both the SARS-CoV-2 and influenza circulating.
Great, thank you. What is the probability that someone can be asymptomatic and infect others?
So I can't say an exact probability, but I think the data are clear on this, that some people, when they acquire the virus, do not have any symptoms, and that during that phase, the virus can be transmitted to other people. So it's quite clear at this time that asymptomatic transmission does occur and is part of the reason that it's so difficult to contain this virus and stop its transmission.
Thank you. We've had quite a few questions with people who are going through chemo treatments, unfortunately, during this time. What can you say about that? How can they better protect themselves, or what's your thought on that?
So undergoing chemotherapy and a variety of other medications that suppress the immune system definitely puts individuals at a higher risk for all kinds of infections, including this one. And so, during that time when the immune system is not functioning at an optimal level, individuals have to be extra cautious. Even before the pandemic, that was true, but certainly during this situation, should be very, very vigilant. And not only the person whose immune system is undergoing that kind of a challenge, but also those around them need to be very careful about their own exposures, especially if they're a household contact of the person who is undergoing chemotherapy or has an underlying medical condition. So we really all need to watch out for each other and consider the consequences of transmitting unknowingly a virus to someone who is more vulnerable because of that condition.
Thank you. After having COVID, when is a person no longer contagious? Is that possible to say?
Yeah, well, it's not an absolute, but the current guidance is really that all other things being equal, so for a relatively healthy person who gets healthy before they get COVID-19, not immunosuppressed, not a transplant recipient, if their immune response is relatively normal, we would expect that they would not be infectious after approximately a week after symptoms onset, and at least several days after fever goes away, and that the symptoms don't have to completely be gone, but they should be improving. And so for most people, that's somewhere, around 10 to 14 days or so, if you have a relatively intact immune system. For people who have had a transplant or are immunosuppressed, the illness can go on longer and viral shedding can go on longer. And so for those individuals, we recommend getting a test at about day 14 or so to see if the viral shedding is still going on. And it's a little bit more complicated, but there's a test-based strategy to determine when you're no longer potentially contagious.
Thank you. We have about a minute or so, or less. So just one last quick question. Do recovered patients need plasma transfusions?
after recovering from the disease, do they need plasma? No, typically not. But one therapy that I didn't mention earlier is convalescent serum. So after someone does recover, the theory of that is that they do have antibodies that might help others prevent getting sick. So there are ongoing trials of convalescent sera to see if it prevents disease.
Great. Well, we're approaching the end of our webcast, but we still have so many questions. An updated and trusted source of information about COVID-19 can be found on our website, hopkinsmedicine.org. At this time, I'd like to thank Dr. Maragakis for her expertise and time this evening. And I would like to thank all of you for joining us this evening. Have a good evening and stay well.